So a lot of people out there, and I'm going to kind of summarize 10 years of work like we asked Frank to do. How does value-based insurance design actually work in terms of increasing medication adherence and impact on spending? We were fortunately able to publish an updated review of the literature on VBID programs and medication in the July issue of Health Affairs, and what that showed, that 21 studies showed a range of medication adherence improvement. That depends on the baseline and the incentives that were provided. But the really important message in terms of moving VBID forward is these increases in adherence, and most of the studies included in this review included diabetes, was associated with no effect or impact on total healthcare spending. So you got the improved health at no incremental cost, which is a very important driver to many of the public and private payers that we're working with. I'm just going to quickly throw through a couple slides about those of you who are learning about VBID for the first time, and it may be hard, it may be intuitive, but there's inertia to overcome. I think it's very important to remind some of you in the audience that even though you think you're not doing VBID, that every private and commercial payer in the country has implemented some part of a VBID plan through the VBID provision in the Affordable Care Act, which mandates that all non-grandfathered plans cover, without any cost sharing, any service with an A or B rating from the U.S. Preventive Services Task Force, all the immunizations recommended by the ACIP at the CDC, and additional preventive care and screenings for women's health and children through the Health Resources and Services Administration. So although many of you may not think you're in health plans that have value-based insurance design, I would guess that 2/3 to 80% of you on the phone have received some expanded coverage of preventive services because of Section 2713 of the ACA. And I like to tell people, as I'm going to try to speak quickly, Obamacare is a 900-page law. All I ask you is to like 1/2 of one page, which is the 1/2 of one page the VBID Center helped write. And the very good news in following public support for removal of cost-sharing preventive services, in the fact that every survey ever done of the ACA has put in the elimination of out-of-pocket costs for preventive services in the top 3. And the very good news is Section 2713 was preserved in all of the 40-plus repeal and replace plans that moved through the Congress 2 years ago. We've also made some strides in adding value-based insurance design to the Medicare program. The Medicare Advantage VBID model test is the first demonstration ever that allowed disease-specific cost sharing for specific services. Importantly, diabetes is one of the conditions that's specified by CMS, has been included in some of the demos underway, including some of those that are planned to launch in 2019. I like to point out that the demonstration was started by the Obama administration and was actually expanded by the Trump administration. And as far as we know, it's the only demonstration that actually was expanded on the new administration that was existing already. We've also made some implementation of VBID in the TRICARE program. There's one of our great Hill champions, John McCain, who helped us write legislation to allow VBID principles in the TRICARE program. I'm going to close quickly, kind of tying Frank's presentation to the solution we're really trying to look at and for. In the fastest growing type of health savings account high deductible health plan, which I believe 29% or so, if you look at the Kaiser Family Foundation survey, Americans are enrolled in these. This is a very attractive and the fastest growing type of health plan. For patients like Frank and patients like mine with diabetes, they are very much hindered by the fact that current legislation does not allow these HSA high deductible health plans to allow pre-deductible coverage for any of the high-value services that I mentioned and that Frank noted. So we have been working both with the Trump administration and Capitol Hill to introduce legislation to allow health plans the option to cover things like medications that lower blood sugar, cholesterol, and blood sugar, as well as those services like eye exams and foot exams that are currently not allowed to be covered on a pre-deductible basis. And here are the bill numbers now. I think that any of you working in an organization with a government affairs person may want to look into this if you're interested in potentially pulling a lever that might mitigate some of the issues that Frank articulated in his research. So the last thing I'll say very quickly, I know it's lunchtime for those of us on the East Coast. For Kim, it's still breakfast. But Many of you are focusing on the move from volume to value with payment reform initiatives. I call that peanut butter. I believe we are actually moving from volume to value on the supply side or the peanut butter side. However, my view is that with the growth of these high deductible health plans and the lack of nuance in terms of what is covered pre and post deductible, that what's happening on the patient side or the demand side that I call jelly is actually pushing our patients away from volume to value. That it's my hope that with some of these policy levers, with VBID one of them, that we would actually have a situation where it would be easy for clinicians like Frank to do the things that's right for his patients, and also easy for his patients as opposed to hard to do those things. And we do believe that there are peanut butter levers like payment reform and consumer levers like value-based insurance design that would bring us to this situation that I hope, really hope, would kind of transform the healthcare conversation in this country from how much we spend to how well we spend.